Mhm.
Okay,
There we
yeah,
go.
thanks. It's over to you, Colin.
Well, thank you, John, and thank you for those kind words of introduction. And yes, 1999, I started working in Newcastle at the Freeman Hospital on Ward 16, the liver ward. And I remember meeting John and Joan and the rest of the team, well, pretty much straight away, actually. And then over the years, it's become a very comfortable and enjoyable working relationship, working with LIVErNORTH and all of you good people. And actually, I can think of, well, lots of different projects. So we're going to talk about one in particular, which LIVErNORTH has supported, which has made a huge difference to liver transplant and patients with liver failure in the Northeast. And I will try and focus on that as we talk. So, what I'm going to talk about is the future of donated organs, and hopefully, I can get my presentation to share. Now, is this going to work? I hope so. But I want
It's
to
saying it
go.
is, so
Mhm.
Is
It's
it
fine.
sharing this? It's just sharing the
there we
Yeah,
go. Yeah,
sure.
I got your screen on now.
Yeah.
So have you got the full thing or have you just got
Yeah, I've got
the
the full thing. You need to switch on to slideshow mode.
okay, so if I go to here, there we go. Is that working? Is that all show?
Hasn't happened yet, but that's it.
Yeah.
Um
Perfect.
John, John, can you ask people to mute their microphones, please?
Can I
There's
what?
a, can you ask people to mute their microphones? There's a little bit of
Yes,
interference.
I'll mute them all.
Thank
Can you hear something?
well hopefully you can hear me.
Yes.
Yeah, we
Oh
must
yeah, well,
mute.
can you mute your microphones, please? Because I can't mute
Mm.
everybody. I'll mute Colin. Okay. Please mute your microphones.
Right, here we go. Let's see how we get on. So this is what I'm going to talk about. Is the slides moving forward? John, can you give me a thumbs up if it's moving forwards? Yes, excellent. Right. So if there's any problems, just wave at me, John, because I can see you and tell me to stop or move or whatever. Anyway, so I'm a transplant surgeon and liver, kidney, pancreas transplants and academic research around them. And the big focus is dealing with this problem, which is the fact that every year we have about 1,200 potential donors, and then we only do 800 or 900 transplants. And actually, this problem isn't going away. Indeed, it's getting more complicated, and we'll talk about why that is. So it's always a challenge finding enough organs for patients that could benefit for transplantation. And there's no doubt at the moment that we limit who can access transplantation because we know we just don't have the organs. So in the future, we're looking and currently at ways of expanding the number of patients that can access transplantation and making sure that the organs mean that they're going to get good outcomes. And these are the topics I'm going to talk about over the next 25 minutes, half an hour. So we're going to talk about machine perfusion and LIVErNORTH's contribution to that. ARCS, which stands for Assessment and Reconditioning Centres, and that is very much part of the United Kingdom National Health Service, blood transplant. This is where we're going at the moment. Advanced therapies and AI. There's no escaping AI anywhere at the moment. You blink and you see AI. So we're going to touch on what that's doing in this space as well. And then we're going to talk about robots and live donation and what that potentially means for us in the UK and what's happening around the world as well. Xenotransplantation, that means using animals as donors. And so we're going to talk about what's happening in that space. Some of you may have seen the headlines and the newspapers. And is it really an alternative? How long before it actually becomes mainstream clinical practice? So this is the challenge. This is what my research is focused on, and I lead a theme as part of what's called the Blood Transplant Research Unit, based in Newcastle and Cambridge. We have a team of researchers and scientists and surgeons, and we're trying to maximize organ utilization. But the problem we have is around death. So back in the 1970s, we codified, as did most countries in the Western world, a criteria for diagnosing brainstem death. And what this meant was that we recognized that people could have a beating heart, be breathing on a machine, but still be dead because of these tests that we came up with. And we realized that people could be dead even though their heart was beating. And that became the kind of standard for how we managed to use organs for transplantation. And what we were looking for, and we had relatively good supply because young people were on motorbikes, they didn't wear crash helmet. And unfortunately, this kind of thing happened, that we'd have an 18-year-old who would have a motorcycle accident, brain would be damaged, but everything else would be intact. And we had an almost perfect liver. And there was, a constant stream of these kind of sad stories, which meant that we did have organs for transplantation. And then what happened, of course, is we became very safe as a country, and we brought in seatbelts, we brought in helmets, and this kind of thing just didn't happen as much, which is a good thing. I'm not pretending that that's not a good thing. So what's happened now is that if we're looking for organ donors, this is the extreme, but generally speaking, we're looking at older patients, other problems like diabetes and high blood pressure to affect the liver, pristine brown organ into this kind of fatty yellow color. And we've also moved more from donation after brainstem death to donation after circulatory death. So because people's heads are protected by helmets, and actually the nature of the stroke injury means you can't diagnose brainstem death. And so more and more we have to actually turn off the machine. An intensive care doctor sitting with the family says, I'm sorry, your loved one is never going to make a meaningful recovery. They're always going to be severely brain damaged. So on that basis, we think the right thing to do is to switch off the machine. And the problem with that is that the organs then get starved of oxygen, and clots form within the liver and other organs at the time of donation. And so we have to contend with this extra injury. Not only has there been this storm of bad signals around the body because of the injury and death, but they also get starved of oxygen. And the challenge there is trying to remove the organs in a way that means the recipient can recover quickly, that the organ recovers quickly, and the transplant is safe. And that is the challenge, because if we put in a liver that doesn't work, then obviously that can be a death sentence to that patient as well. And beyond that, what we've realized is that the oxygen starvation injury to the bile ducts means that the bile ducts become scarred, and bile silts up within the liver, becomes infected, abscesses form, and the liver fails. And we call this ischemic cholangiopathy. And up to 40% of people who receive DCD livers in standard cold storage, the way we put the liver in the ice box after donation, unfortunately up to 40% of patients can develop this condition, and they then need another transplant emergently, or unfortunately they die. And so that's the challenge we're facing. And up to 50% of our donors now are DCD, donors after circulatory death, as opposed to back in even 2020, it was less than 5%. So this has suddenly happened, and to a large extent, and it's not just the UK, it's the US and Europe and the rest of the world as well. Everything is shifted to DCD donation. And there's a number of reasons for that, which I'm not going to go into. So the challenge here is, how do we make these organs transplantable? And you can see this graphic from NHS Blood and Transplant, which was the precursor to the ARC program, showing that DBD donors, we get 3.5 organs on average from each donor that are usable for transplant, but DCD it's 2.8, and of course this changes. But so although we've got the same number of donors, we don't have the same number of organs for transplantation, and so we have to turn to advanced technology to try and rescue these organs that have been starved of oxygen. Now, back in 2013, when I was starting as a consultant in Newcastle, Derek Manus sent me off to Oxford because a guy called Peter Friend, who's in the middle of these three pictures here, had developed this machine to pump oxygen in red blood cells around livers and try and revitalize these DCD organs prior to transplantation. And this machine was a great success. It started slowly, but it's built up, and now it's used around the world. I was talking to the company, and they've done over 60,000 liver transplants using that machine. And the company was sold to a Japanese company for 1.5 billion last year. So if you had shares in OrganOx, you've done very well. But this is where I come in with LIVErNORTH and say I was very grateful to LIVErNORTH because they clubbed together with us, and we bought this machine, which was badged with LIVErNORTH back in, I think it was 2016, 2017, and we moved it into the Freeman Hospital with all of these complexities and difficulties, and the team began to train on it and use it. It's a lot more complicated than just having a cold ice box. It takes time, and if you get it wrong, actually you can damage the organ as well. So we had to try and make sure we were being safe. But the great thing is you can get all these numbers back from the machine about how the organ's doing, how it's responding, what the blood flows are like, how the acid-base balance, the pH, what bile is being produced. And that's really reassuring for a surgeon to see the liver producing bile. That's a good sign. That makes us very happy, thinking, oh, this is a healthy organ. And then you can go to the patient and say, we've got it on the machine, it's producing bile, it looks very healthy, let's go ahead with the transplant. And very reassuring for patients. But also we can move the transplant. Instead of having this quick turnaround of 8 or 10 hours, we can now go out to 24 hours or even 30 hours on the machine. And actually we can try and schedule the transplant for the daytime, which obviously means the patient experience is better. And it also means I can have my 3 Weetabix, a good night's sleep, and make sure that I'm ready to go in the morning. So we're using red cells and the other additives. So heparin is a blood thinner, and we can give steroids which dampen down inflammation, and antibiotics to treat any bugs. And so that's what we currently do. But of course, you can imagine that we can add other things to this to try and improve the liver. So in 2019, we did our first liver transplant in Newcastle using this machine, and it was a great success. And we've done multiple transplants using this machine after that. We've also used cold pumps to pump oxygen under a cold temperature. But with the ARCs now, we're moving back towards this kind of machine because we can transport it on this machine, the OrganOx. It goes in the back of a van. So the liver can come to Newcastle. We perfuse it. This is a very complicated scheme, pathway, program, whatever you want to call it. But actually what you can see here is that you've got the donor center. So there's lots of different machines now. So the organ can come out of the donor, and we could put it on a standard ice box, static cold storage down here, and then we can put it on the pump when it gets to us. Or we could do the pump from the donor center, but that's more complicated because the donor could be in Plymouth, say, and how do we get the machine to Plymouth? And then we could also put it on a cold pump and then put it on a warm pump and warm it up. Or we could just pump the liver in the body at the start. This is called NRP. And also we could just do normothermic without even stopping. There is a way of doing that now. But more and more we're moving to what's called the ARC model now, where the liver comes out of the donor, goes in an ice box, comes to an ARC center, and we'll talk about where they are, gets put on the pump, tests are done, treatments are given, and then a kind of MOT is produced for that liver, and the MOT is shared with a surgeon in another center, and then the liver moves to that center, and everything is done in very controlled, slow time, making sure that everybody's ready and everything is very safe. That's the theory, and that's what we're moving towards. So I put Sam Tingle's picture up here. This is Sam. Sam's done a huge amount of work, and a lot of what you're going to see is his work. And he's coming towards the end of his PhD, and he's going to restart as a surgeon in the Freeman Hospital in August. And he's done some really high quality work, which we're going to showcase as we go along. So this is another one of the things that Sam came up with, and he's showing the comparison between kidney, liver, pancreas, and of course you can put heart and lung in here. We're focused on the liver for obvious reasons. This is LIVErNORTH. But actually what we're saying about the liver goes for the other organs as well. And you can think of the heart and lung going through similar processes and similar potential technologies. So this is kind of just a preface to where we are with ARCs and donor hospitals, organ repair centres, and the transplanting centre. And the plan for ARCs, starting this year, I'll show you the timeline, is not only to put them on pumps and test them, but also to come up with novel diagnostics, give cell therapy so we can give stem cells to repopulate the organ and fill in any gaps where there's cells have died. And we can also give drugs, and we'll talk about potential drugs we might want to give. So this is one of the drugs that Sam tested in livers that were not suitable for transplantation. This is about 5 years ago. This drug, very complicated, 2,4-dinitrophenol, and DNP is very similar to TNT, trinitrotoluene. And what it does, if you give it to patients, and it was the first drug banned by the FDA back in the 1920s, because people would take this drug to lose weight because it boosts your metabolism, it zooms your circulation, and your body temperature rises from 37 degrees to 40 degrees, and you burn fat. And not only do you burn fat in your liver, but your muscles. And the problem was that people were taking it, they were losing a lot of weight. But if they just took a little bit too much, then they'd have high temperature fits and die. And the FDA said that we can't have this, we have to ban this drug. But of course, what we can do is put the drug in the circuit and just treat the liver and increase the temperature and get the liver to burn off the excess fat, which is turning it from that nice brown color to that slightly off buttery yellow color, foie gras. So we give TNT, or in this case DNP, and we can burn off the fat. And Sam showed that this worked. The problem is that the liver burned up the DNP as well, and so you had to give a constant infusion, and that's what this graph is showing. We haven't yet persuaded the MHRA in the UK to let us use this drug in clinical transplantation. Hopefully in the future, though, we can convince them that this is a good idea for defatting livers. The other thing that Sam showed on the pump is that despite the heparin, the blood thinning agent, actually you get clots forming within the sinusoids, the little blood vessels within the liver. That's what this is showing here. And there's ways potentially of getting rid of that. One would be a clot busting drug like we give to patients having a heart attack called alteplase. And there's a team in Cambridge who I'm working with who are doing that. And we've got a trial now, which is imaginatively called Clot Bust. You know, someone spent a lot of time thinking about that, the name of the trial, Clot Bust. But we've got a guy in Newcastle, Bala, who's been working with me, who's done some really excellent research looking at complement. Now, complement is a series of proteins manufactured in the liver, and its role is to protect us against bacteria. And these proteins attack bacteria. But when your liver is damaged and when your blood vessels are damaged, actually you lose the proteins that stop that attack on your blood vessels. And so the loss of these defensive proteins means that these attacking proteins attack your own blood vessels. And what this means is that your own blood vessels, then clots can form. And that's what we think has happened in the livers on the pump, is that these attack proteins have reached huge levels, the complement in the circuit as it's going round. So you can see here it's going up to 200. The normal value is 10. So it's about 20 times what we have in a normal human, this level of attack proteins. And because of the DCD injury, we've lost the defense proteins and the complement then attacks the liver. And it's a phenomenon called thrombotic microangiopathy. And that's important because we'll talk about that in 5 minutes. So innovation in organ transplantation. This is the business case that NHS Blood and Transplant created. Very complicated slides, lots of data, basically asking the government, we've got this problem. We have all of these patients waiting for transplantation. We have DCD organs and we can't use them without pumps. Please, can you finance the ARC program? And Professor Stephen Powis, who happens to be a transplant nephrologist originally at the Royal Free Hospital, was very supportive. And this program has been developed by, Derek Manus, who many of you know, and Derek is the medical director of organ tissue and donation in the UK at the moment, and he's really pushed this forward and secured lots of funding for patients with organ failure needing transplantation. And we're going through this very prescriptive development phase to show, first of all, that it works, and then hopefully we're going to get recurrent funding in the long term. You've kind of seen this already, complicated slides, but basically the organ's donated. It's put on a box, standard static cold storage box, comes to the ARC center, then it gets the pump and the MOT before going to the implanting center. And not only for liver, but you can see for lung here and also for kidney. These are the 3 organs that we're focusing on at the moment and trying to increase the number of transplantable organs. So of the 7 liver transplant centres in the UK, the 5 in red here have bid to be an ARC. Newcastle have been financed as part of the pilot phase along with these other centres. And the idea in the long term is there's going to be 2 or 3 centres, one in the north of the country and one in the south. Obviously, hopefully in a pretty good position in Newcastle to show that we can do this effectively, not only because of our position in the north, but because of our expertise, the support of organisations like LIVErNORTH, and also the fact that in the Freeman Hospital, we're the one hospital that has liver, lung and kidney all in the same place. So we're really focused and we're really set up to do this. And I'm pleased to report that the team, Newcastle upon Tyne Hospitals Trust, has really backed us and supported us and given us a fantastic ward to develop this. And this is an operating theatre environment. We're calling it the Newcastle Organ Assessment Hub, NOAA. So the Newcastle ARC is NOAA. It all fits together so nicely. Anyway, someone's obviously spent more time on that than they have on Clotbust in designing that acronym. But NOAA and his ARC is up and going, and I've been posting on LinkedIn and saying thank you to everybody who's doing the hard work. And it's great to see the perfusion team here working and enjoying it and seeing or making a real difference to patients. And you can see there our new surgeons as well, Emily Thompson and Rodrigo Figueiredo, who's a key part of this and leads the organ team through the training process in those pictures. So the Institute of Transplantation, the ARC is now based in it, and Freeman is at the forefront of that. Behind all of this, though, is NHS Blood and Transplant, and there's this huge infrastructure of governance and people making sure that we're all doing what we're meant to be doing. And there's lots of paperwork and lots of meetings to make sure we are on track. And then there's all of these other things that are coming in from various different sides, different programs that have to interact with the ARCs. So it's a highly complex environment. It's not just putting an organ on the pump, unfortunately. As a surgeon, that's the good bit. I'm afraid there's lots of meetings I have to attend as well to make sure that we fit in with what else is going on. I put this up just to say that the research that we're doing as part of NIHR will be part of this as well, part of the ARCs, and these all fit together really nicely here in Newcastle. And ultimately what we're trying to do is answer the question to transplant or not to transplant. And the MOT that we're doing on the pump is a significant part of that. But what we've realized is that machine perfusion viability doesn't take over from the most important thing, which is the surgeon's experience and the surgeon's eyes. And it's the number one reason is the surgeon looks at the liver and says, I don't like the look of that. I am not going to take a risk on that, despite what you tell me about it, because it just doesn't look right to me. But we know that if you take an organ, and 2/3, this big red chunk of the pie chart is organs that are discarded, livers that are discarded because they look too yellow, too fatty. And if you send that to an expert centre, in this case it was Birmingham, and put it on a pump, actually you can show that that organ is transplantable. So what we've been doing alongside the pump technology is developing AI, computer vision technology. And this is George Karunis, again, another fantastic talent who's developed this computer vision AI tool. We've trained it, 26 different surgeons, 12 different countries, thousands of organs we've looked at, and we've brought all of that experience together and trained an AI algorithm to do it for us. And Joan Bedlington, Joan, thank you very much for being part of this and driving forward the patient and public involvement. And we brought all of that together. And what we have now is an app. And I'll show you what the app does on the phone for the surgeons. For obvious reasons, we don't let everybody have access to this. But this is for surgeons and for scientists, that they take photographs of the liver, and we want lots of different pictures. You click on it, you upload it, and then it goes to the server, it's processed, and it comes back with a score saying, in this case, there's no fat in this liver, this is a good liver. So this is AI in action, but this is what I would call the kind of right kind of AI, because we don't tell the surgeons what to do, we just give them some information, some more information which they can rely on, which isn't one person's opinion. This is like having 26 surgeons on your shoulder telling you this is what the organ is like, and in this case you should accept the organ. It's a huge amount of work, lots of time and energy invested to get us to this stage, and we're now running a trial, and this is a key part of what we need to do, is to show people, not just hand out the technology and say it works, trust us, but actually generate the evidence. And Sophia Casaruni here is a foundation doctor who's come to work with the project. She's driving forward the trial here in Newcastle, but it's going to involve all the 7 liver transplant centres. We're not going to use the app. We're going to attach it directly into the transplant path platform that we all use to share information about donors. And so that's the next step of this. And this trial is going on, hopefully still negotiating some hurdles. I've been writing replies to them this week saying, yes, we have a lot of testing. Don't worry, it is going to be okay. We have looked at all of the potential risks, and then see if we can get this to work and make sure, the idea being we want to use more organs that have been discarded. We want to use them because the computer vision says, look, just don't worry about it. It looks okay. I know you had a bad experience last week, but I'm telling you this liver's okay. That's the thing we're looking at. So for the last 2 or 3 minutes, I want to just broaden the conversation. In the UK, we're very focused on deceased donation because we have a well-integrated NHS. We can share organs. People are dying in a position where we can actually make sense and make some use of that slightly horrible moment. But of course, in other places around the world, deceased donation is just not possible because of political or religious reasons. And live donation, taking half of someone's liver and giving it to somebody else, is possible. It's a big operation, and there is a risk, of course, that not only does the recipient not do well because there's not enough liver given, but that you take too much liver and the donor does badly. So you could end up with both the donor and the recipient dying. And unfortunately, there's been bad stories of this happening everywhere, which is why in the UK we focused more on deceased donation, because the donor is already dead, thankfully, or unfortunately, depending on which way you look at it. Anyway, but if you go to other countries, live donation is becoming more of a thing. And of course, robots now and robotic surgery is becoming a lot safer and a lot easier. So actually what's happening in a lot of places, we're moving from doing kind of big open operations and splitting the liver in half to doing keyhole operations with the robot assisting. And this is really taking off. And if you look at some of the reports, particularly from Korea or Saudi Arabia or the States, some centers in the States, they're getting amazing results. And certainly in the UK, we want to try and do this more often. And again, Derek's driving this forward. bearing in mind that we have to be really safe. And I think the focus is going to be on centres where children need liver transplants. The reason for that being, of course, with a child, you have two parents, mother and father, both want to help that child, and they don't have to give half their liver. They can just give one small portion of the liver called the left lateral segment. So actually, that's a much safer operation, much easier to do. It's difficult to get a normal size whole liver for a child, so it's easier to use a small bit from a live adult donor for that particular baby or child. And because they're doing that, because they're using those skills, actually they become very practiced at doing it and become better at doing adult to adult liver transplantation. So the focus has always been on child centres. So that's London, King's College in London, Birmingham and Leeds. Of course, Leeds isn't far away from Newcastle, and so there's a number of patients in Leeds who've gone down this route, and they're going to support the team in Newcastle, and we're going to hopefully have some live donors potentially happening in Newcastle as well. And if you need a liver transplant yourself, you should be thinking, is live donation something that I should be looking at rather than waiting for one of these pumped livers, which may or may not come along when you need it. So we can talk about that if you want to in the Q&A afterwards. Now, the other thing, of course, is xenotransplantation, a never-ending potential source of organs, because we all like pigs. We all have pigs around. We started off looking at great apes, gorillas, and chimpanzees as donors, and of course, they're closer to us genetically. However, for obvious reasons, we're not keen to go down that route now in the future and looking at animals that are so close to us. But pigs, we all like pigs, and farm animals are probably the kind of animals we should be thinking about. So pigs have lots of different proteins on their cells, and it means when you put in a pig organ currently into a human, it's rejected straight away. Antibodies bind to it, destroy it, and you can't even get the organ off the table. So what's happened now is a company called eGenesis in the States have created a pig which has 10 different human manufactured mutations to remove 10 different proteins or add those kind of protective proteins to the cells. So suddenly we can potentially do pig transplants. And the first one was 2021. And so it was a kidney producing urine, and heart transplants have been done because, of course, the heart just pump blood. It just has to do one thing. This very complicated side tries to explain all the different things that your liver does and how different the pig liver is. It creates different proteins. We want the pig liver to create human proteins. So there's that problem to start with. There's the immune problem. It just looks so different. The proteins, these xenoantigens, as they're called, alpha-gal. And even though we take out 10 different proteins, there's still thousands more. So although pig livers are potentially a source of life-sustaining treatment in the short term, we are a long way off being able to do it in the long term. And the other thing with pigs, which you may not be aware of, and the reason I put this slide up is this viral transmission risk. Pigs have viral DNA embedded within their own cells, within their own genomes. They're called PERVs, porcine endogenous retroviruses. So one of the risks and one of the concerns is that you give a pig organ to a human and those viruses jump across into the humans and become a mutant. And a mutant that then could potentially be transmissible from human to human. Now, we think we've probably seen that quite recently, and it created the SARS-CoV-2 COVID in 2019, that a animal virus jumped into humans and we had no defense against it. Hence, it spread so rapidly and killed so many people across the globe. So this is one of the major concerns with doing these kind of pig to human transplants is we will create mutant viruses and we'll create a plague that we cannot contain. So everything is being tightly regulated in the US. I'm not sure what's happening in China, and that is a cause of concern. And the big thing that's happened that even despite these 10 mutations being made to these pigs, and each pig is over $1 million, they're so expensive to create. So even with that, what's happening is our complement system, that thrombotic microangiopathy I was telling you about is happening in every xenotransplantation to date. They've all failed within a year, despite these 10 mutations, and they all develop this complement injury on the blood vessels, and our immune system destroys them. So we've still got quite a way to go. And we've made big strides compared to the 1960s and Sir Roy Khan. When they tried with baboons, we're way ahead of where we were then. But the more we learn, the more we realize we have more to learn, if that makes sense. There's a long way to go. So I'm going to finish there. I've introduced various different things, and there's lots of people, particularly with liver confined cancer, that could benefit from transplantation. And we're seeing that now, that with the modern drugs, we could treat so many people with cancer with transplantation. But we need to find enough high quality organs that mean that people can have safe transplantation. Live donation, I think, is going to become a routine reality in the UK, as it is in other parts of the world. Now, xenotransplantation, yes, we've still got a way to go. Machine perfusion and ARCs are the focus in the UK, and I would exhort you all to encourage organ donation any way you can, because there's no doubt, with confidence in the NHS being not as high as it has been in the past, let's say that people are less willing to donate organs and trust doctors, and hopefully we can change that and get back to being saving lives on a routine basis with real confidence in the years to come. So I just want to say a big thank you to the organ donors, obviously, who've made all of this possible in the years. It's a huge team of people, lots and lots of people. It's great to see Joan and other people on the call who've been such a part of this kind of research, which has really helped in bringing transplantation to more people and saving more lives. And I'd be very happy to answer any questions. And thank you to LIVErNORTH. Thank you to you all for all your fundraising efforts and making sure that this is something that we're all part of.
Thank you, Colin. We'll stop sharing if we can. Is that okay?
Yes, sorry, I'll just work out how to do that. Sorry, I overran a bit. Apologies.
No, it's fine. It was absolutely fantastic. Well, thank you to you for all of your dedicated work on behalf of liver patients and for coming today to talk to us. And we know that if you were private, it would have cost us about 500 quid for that chat. So that's very good that you're doing it. We pay you in virtual merry mints. That's what we usually pay people in. They're not real merry mints, they're virtual ones, because we can't afford anything real. So that's amazing. If anyone has any questions, if you'd like to put your hand up, you can put a virtual hand using the machine, or you can put a real hand. So I've got Yvonne, please. And you're muted, Yvonne. You're muted.
Can you hear me now? Yeah, thanks, John. Took me a while to find my unmute button. Thanks ever so much for that. That was really fascinating. I'm just wondering, with the increase in the weight loss drugs, I'm just wondering whether there's a potential of perhaps getting livers that are not quite as fatty.
Absolutely. So thank you for that question. That's really interesting. And it's one of my kind of favorite topics at the moment is that, so I see Mounjaro, Ozempic, these drugs that we hear about in the news, and probably some of you are using, which I see them as are going to change everything. I think they're going to change a lot of what's happening. And I'm just going to tell you a story about a patient I saw a couple of months back, a 28-year-old who came in with gallstones, and I went back through his history, and he'd been very big, 190 kilograms 2 years beforehand, and he had high blood pressure, he had fatty liver disease, and his kidneys were struggling. But not only that, his hips and knees, he was struggling to move around because of all of those different problems. And then he got access to Ozempic, and he was put on Ozempic, and he lost a huge amount of weight, came down to 90 kilos, but did it in a very controlled, healthy way, and managed to increase his exercise at the same time. And all of his chronic conditions, including diabetes, had gone away. He'd been on 12 medications 2 years ago, and here he was. He was off his blood pressure tablets. His fatty liver disease had disappeared. His hips and knees were better. His kidney disease was better. Everything was better. And I think it's going to change everything. I think it's going to change the people who are struggling with liver disease. So we've successfully cured hepatitis B, C, all of these diseases, viruses with drugs. I think we're going to get rid of fatty liver disease as well with these drugs. They also stop people drinking alcohol. People don't want to drink alcohol because it's they just don't like the taste. They don't want it. They don't need it. So it's going to get rid of that, which opens up the opportunity potentially of patients with cancer then being able to access these organs for transplantation. So I can see everything changing. I can see fatty liver disease not being such an issue in the future. And I can see you're not needing hip replacements, knee replacements, not needing kidney transplants, not needing coronary artery bypass grafting, but you're still going to need transplants.
Yeah. No, that's great. Thanks. Yes. Yeah.
No, exactly. And people say to me, sorry, because I deal with pancreatitis, and that's one of the commonly reported complications for these drugs, saying, horrible horror story, this person died of pancreatitis. I just don't see that. I see the benefits, but I don't see lots of people coming into hospital with complications. And the scare stories and the horror stories are not what I see. I just see the benefits, I have to say.
Oh, thanks for that, Colin. Thanks.
Excellent. Thanks, Yvonne. Joan said she wants to say something. She's now down over my left shoulder.
I can see that. Yeah.
I couldn't put my hand up on the laptop. I was at a meeting down in Birmingham recently, and live liver donation came up as one of the topics. Anyway, in the next newsletter, which will be due out in about a week to 10 days, there's going to be an article on live liver donation. It's not very long, and I wrote it in collaboration with Lisa Berner. But it does give lots of links where you can get some more information if anyone's interested.
No, brilliant. I mean, there's a real push at the moment to try and get people access to it, because if we're going to move to doing transplants for patients with cancer, then it's going to be important to have organs available tomorrow, not in weeks or months' time when the cancer's progressed. So that's all part of the strategy, is to say, well, look, if you've got a potential live donor, we'll make sure we can do it safely.
Good. Liz, you've got your hand up. You're muted.
There we go. A lesson in how to learn how to use the computer. I have autoimmune hepatitis, and although I don't need a liver transplant right at the moment, because as John knows, I do things like climb mountains and run marathons and stuff like that. But would my autoimmune condition transfer to a living liver donor? Would my condition preclude me from having a liver transplant if and when I get around to needing it? I mean, I have a liver full of cirrhosis at the moment. I mean, it really, it's knackered, although it's still chugging on. But What's the situation for autoimmunity as far as liver transplants are concerned?
So as a recipient, absolutely, that's not, you can receive an organ, but because you have an active immune system, you are at more risk of rejecting the organ just because, you've obviously got very, active immune system. And some people's immune system is not active, but yours is. And so you are more at risk of rejection. But if you were to give an organ, that wouldn't be a problem. It's all about the recipient's immune system.
Thank you.
Great.
Thanks for that, Liz. I've got a question, Colin. We had a talk in where was it? York, with Derek was the chair about live liver donation. I don't know, you weren't there actually, if I remember rightly, but it was apparently one of the most successful procedures you could possibly have. And at the time, there were very, very few failures. But I get the impression now that there have been a few recently.
Well, so I'm not up to date with the numbers. The problem is when it happens, it's such a disaster that everybody remembers it. And I have 2 or 3 memories, not in Newcastle, of other centres of what happened and who was involved and listening to their stories. And it leaves a big mark on your conscience and thinking, well, if they'd just taken a liver from a deceased donor, then we wouldn't have had that problem. So what you don't remember is all the good stories. You don't remember all the ones that have gone really well as a surgeon. You remember the ones that have gone badly, and that's the bit we need to get past. Is that in our game, there's always risks, and things do go wrong occasionally, and they leave scars. But you have to move on, and you have to try and remember all the hundreds of people who've done really well. So that's the challenge for us, and the media can be really unkind in these situations and accuse everybody of everything. And that's the other thing that we have to get past is that if it was to happen, how the media would look at it and then the lawyers as well. So there's a lot of people who circle round to keep reminding us if we make a mistake.
I know it's awful. It's blame. The prosecuting soldiers from Northern Ireland now, 50 years.
Yeah. I mean, that's just taken completely out of context.
I know who's going to join the army now and act under orders. You see, I'm not doing it.
Well, exactly. Just when we need them as well, as Vladimir Putin is
Absolutely.
flexing his muscles. Anyway,
that's diverting from
yeah,
the talk.
I could talk about that for hours as well.
Oh, same here, Colin. Same here. In fact, Liz was in the RAF for a long time. She was,
Brilliant.
and she walked through the Arctic Circle for us in 400 miles.
There you go. Perfect.
Any other questions from anyone? Oh, yes, Jane, all the way from Penrith.
I just wanted to say thank you for sharing, Colin. It's like I had my transplant 2.5 years ago, but it took 6 calls and 2 years, and it's like so reassuring. Like you don't realise when you're stuck in it what it's like, and to see that for people moving forward, because as a patient you become involved with other people who are waiting because you want to do your bit and help them, and it's nice to know that there's things moving forward that you can share with them and help encourage them that things are going to improve.
No, absolutely. Thank you. And yeah, I mean, this is the problem is that we're calling people up because we want to keep the time in the box really short. And so we call people up, bring them in, and then we find the organ's just not suitable. So more and more, this is what's happening. And things like Orca, where we take the picture at the start and we get a quick result, a quick answer. Hopefully that's going to reduce the number of organs because we could shorten that ischemic time if we're not using a machine. And then if we are using a machine, we know which machine it should go on to be useful and be usable. And I didn't put up any of the facts, but about how many organs we're not using at the moment. And it can be a bit depressing that people are donating organs and they're not being transplanted.
I know, I was B negative. I was like I was on the variant list and I was B negative, so I was end of the line. So when it got to me, there was nowhere else for it to go.
And that's one of the challenges is blood group at the moment. And if you're blood group O, it can be difficult. You are waiting longer. And one of the programs that I'm involved with in Cambridge with Mike Nicholson's group is changing the blood group of the organ as well. So that's, hopefully we can get rid of these blood group issues as well. So everybody's in the same boat.
Yeah, no, it's really good.
Excellent.
Thank you for sharing.
Joan's got something. Thanks for that, Jane. Excellent. I mean, we remember you when you needed your transplant and when you were waiting for it, and now you've had it, and you look brilliant.
Yeah. And I've never looked back. So that's like since I left there, I've never looked back. So that's
Right.
amazing, isn't it?
So, Joan has something else.
Yeah, I was just going to mention the Orca trial, Colin, and to say that about the little animation, which is useful for people to look at if they want to understand it more.
I haven't got the link. I should have got the. That was a. Where is it?
It's all right. You can email it, and
Well, you can find it quite easily on the website anyway.
Yeah, we'll
Yes.
sort it out.
We'll send the link
That's
down so
absolutely
people are aware.
absolutely brilliant. And thanks for that
didn't
remark,
think of
Liz. And I mean, you echoed what everybody says. Thank you so much, Colin, for all of your dedication. I know you're juggling balls in the air all the time, and I don't know how you do it.
Well, it's
but
the
we're
big
here.
team of really amazing people, and I showcased 3 people: Sam, George, and Sophia. But there's been lots of other people, Bala, and we're very lucky that we still managed to encourage some really high quality people to want to come and work in the NHS and want to come and be surgeons and do this kind of work. So yeah, it's to be honest, it's them that keep me going. There's young talent coming through.
You're doing a great job. Well, Carol King. Carol, you wanted to say something?
Yes, hi there. Just want to say and to echo Jane's words. As a liver recipient, mine was a DBD donor and CMV negative to negative. And I had my transplant at Queen Elizabeth in Birmingham
Oh, right.
6 years ago, last month. So I'm 6 years old. And just want to say that since then, everything's changed and moved on. You've got perfusion machines,
Yeah.
you've got everything, and it's just absolutely incredible and amazing. And thank you for, the kind of news updates and refreshing information. And it's always good to hear that kind of thing. And
Yeah.
obviously, we all appreciate, like Jane does, our donor families, and without them, we wouldn't be here. And
that's
it's a
brilliant.
really two-side story, isn't it? Someone dies to help you live, but that's their choice, and that's why they sign up. So thank you for that, and really enjoyed listening to everything. And the advancement of the pig to human, that is, it's something which I looked at and thought, not sure, because of obviously where I am, but nowadays, with the advancement of technology and everything in AI, it's quite incredible. And the statistics, when I was reading of the TMA, the rejection is still really quick.
Yeah.
Really quick. And also to talk about Liz and her autoimmune system, mine was my transplant was due to hepatic sarcoidosis.
Oh, right.
So
Yeah.
mine was an autoimmune system, but that can be controlled with drugs.
Yeah.
So thank you very much. I've enjoyed listening tonight.
Well, thank you,
Thank
Karen.
you, Caroline, for that. Brilliant. We've also had a few things in the chat. Sheena, thank you very much for this interesting talk. Liz, amazing work going on behind the scenes. Rachel, excellent work and dedication. Thank you. Olivia, thanks also from me. I'm coming up to just 4 months post-transplant. And Sean, thank you much, Colin, for the presentation, everything you do. That was really interesting.
Sean.
And
I didn't see Sean was
Fiona,
on the call.
really
Great.
interesting. Thanks from me. So from all of us, Colin, thank you so much for giving us your time. And we'll say goodbye now to everyone. And it'll be available on YouTube very soon. Thank you. Bye.
Thanks, John. Brilliant as
Bye.
always.
Thank
Thank
you.
you.
Bye.
Bye.